Welcome to everyone to our webinar on COVID-19 reflections and the path to recovery.
I think at the end we will have now Q&A, and after that Greg will finish the conference by a few words. Before I move on, I would like to share a small story regarding this conference, which we have put together over the last 10 days only. Greg considered this as the fastest conference ever been done in his career, because he has been doing a lot of conferences. Someone asked me, a friend, how much you have paid Thomas Friedman for this conference. So I paused a little bit, and he said he has been following Thomas over the last 30 years. And he has been reading every single book and article that he has written. I said, you know, I have paid him a lot, but not enough. I have paid him 100,000 thank you as a down payment, but also I have to pay him and pay every single speaker and organizing committee and all of you 1 million thank you for being involved in this conference. Thank you so much. So I will leave the microphone with Sue, and then Greg will end this.
Great, thank you. So we do have a specific question about therapeutics to follow up on the most recent discussion. So there are many at-risk patients with pre-existing conditions, especially including cardiovascular risks. And do you believe, or do any of the scientists on the panel believe, that any prophylactic therapy with ACE inhibitor or ACE receptor blockers would be helpful to decrease severity of disease or mitigate this? And I know you mentioned there are some pending trials to assess this too, and this was also an early theory.
Well, I'm glad we have cardiologists on the panel.
So Fred can go.
Yeah, so I think that there was a lot of interest in this. There's part of the way that the virus is taken up by the mucosal cells in the upper respiratory tract is through the ACE2 receptor. Having said that, my understanding from a series of early observational studies that were done, as well as a perspective piece that was published in the New England Journal, I think it was in June, by Dr. John Jarko, was that there is no association of an improved outcome by either treating with angioreceptor blockers, by starting ACE inhibitors or ARBs, by stopping people who are on ACE inhibitors or ARBs. And so the current, as far as I know, the current weight of evidence is that if patients are taking ACE inhibitors or ARBs, they should continue taking them, despite the fact that they may have upregulated their expression of ACE inhibitors, because the stopping of taking that medication is thought to confer more risk than any potential benefit. The differences in the largest studies have been tiny. Now, I think, maybe some of the other panelists and Dr. Boucher can mention, that there is a very well organized sort of pragmatic trial program in the UK, the Recovery Group, and I believe that they're looking at this and other commonly used therapeutics, and I think it has been mentioned about the role and intensity of anticoagulation, another sort of cardiovascular sort of factor in, in the progression and severity of disease. There's a lot of suspicion about these things, but we really do need these subjects to be investigated sort of most effectively and quickly. And I'm hopeful that the Recovery Group is looking at some of these, and I believe they are.
Yeah, no, that's correct, Dr. Resnic. The Recovery Group is looking at anticoagulation. They're looking at ACE receptor blockers and a number of other repurposed and new drugs. So I think that we will look forward to those. There was a study last week about aspirin being beneficial, but so the latest guideline is that you should just use regular deep vein thrombosis prophylaxis for patients. Now, that said, I know some cardiologists who do more based on certain things. And I think that brings us back to the fact that we're treating the patient before us. And it's really important to think about what we know about each patient when we make decisions, and the guidelines are just guidelines. But for now, that's that weight of the evidence. The other thing I'll say is that I think that for us in our country, this epidemic has exposed a number of what you might call our weaknesses or limitations. And I think our inability to launch a recovery trial could be cited just as that. I mean, the convalescent plasma story is really a shame. The group in New York, led by Lizan Perovsky, is now doing a randomized trial of convalescent plasma finally, but it's a little late, right? And, it's a shame that we're seeing that. So I'm grateful for the example, the leadership from the UK.
Great, thank you. And I'll remind the participants that we aren't able to use the raise the hand function. So if you have a question, put it in the Q&A and we'll try to get to them, although I'm confident we won't get to all the questions. So the next question is related to our discussion of lockdown. And is there any known benefit to curfew instead, as we've heard about timing curfews or less severe lockdown in different geographies?
Yeah, that's a really good question. Even some of these terms are kind of vague, right? I don't think there's a scientific definition of lockdown. And I think it may come from prisons or something. So I don't know. Bottom line is I would envision that curfews probably do have some benefit. Mass gatherings, I think, are a big deal, and those can occur in lots of settings. So they can occur in bars and restaurants. They can occur in sporting events, religious gatherings. And I think that's the key, is to kind of target trying to keep individuals away from one another, socially distanced, if you will. And however that kind of figures into your definition of lockdown and curfew, I think we can just kind of figure that out. But I think the key is to try to decrease the point of contact for so many people, and especially the super spreader events. I was just reviewing the data from North Carolina, where they went through very carefully and categorized all the cluster outbreaks that have occurred. And the number one setting was actually in meat packing plants in North Carolina. Number two was in colleges and universities. And number three were religious gatherings. And there were 88 clusters of outbreaks associated with religious gatherings. So as Thomas Friedman said, this virus, it doesn't care. You can't negotiate with it. And it doesn't matter your religion. It doesn't matter where you work, it's going to do what it's going to do.
Great, thank you. The next question is some advice from physicians who have especially worked in ICUs caring for these patients. And how do you manage patients or families who demand or ask for some of these investigational therapies that are either in randomized trials in another institution or may just have been in the popular media? And then a follow-up question to that is, how liable is the treating physician if not using those things and the patients and families are asking for them?
I'm happy to weigh in on the experience. Things I think are a little different today than they were in the peak of the surge, in terms of there was so much uncertainty about the benefit of so many different interventions. I remember arguing politely with our rheumatology and infectious disease doctors about the threshold by which we should be trying to treat specific patients with tocilizumab or other, cytokine inhibitor strategies, which was off-label, and then we started a randomized trial. So to the question, it's a difficult conversation, and I think it varies, and it probably varies also by the environment that one works in. Certainly in the United States, there's great concern about medical liability if one isn't providing the community standards of treatment. I think there are mitigating circumstances in the setting of a pandemic, and I think the other point was that there was also limited access that's well understood. So even when remdesivir was granted the emergency use authorization, there were shortages and still are shortages that make it impossible to treat all the patients for whom there has been defined benefit and for which the infectious disease experts are recommending it. And this varies. I mean, even in the state of Massachusetts, remarkably, the original distribution strategy for remdesivir was actually by the federal government to hospitals that was not based on the census of COVID patients. And to the credit of some of the largest hospitals, well-known hospitals in Massachusetts, specifically Mass General and others, the decision was made, we don't want to be hoarding this agent. We're giving it all to the State Department of Public Health, and they should distribute it in what we know are limited manner and give it back to us proportionately as you would to everyone else. And I thought that was an appropriate response and a good response. So how do you deal with it? Well, sometimes the true resource limitations of what's available make it impossible. The second is that during this period of the pandemic, at least in most of the northeastern United States, one couldn't transfer a patient from one hospital to another for the purpose of enrolling in a trial. All of the hospitals were of such capacity planning crises that was shut down. So that was off the table. Like if we didn't have access to a trial to try to transfer the patient to another hospital that might have access to the trial, actually got shut down very quickly in April. And I think having honest conversations. Now, I think we are at a different place today, and I would defer to the other members of the panel. We know a lot of things simply don't actually make a difference. And so we're getting more so we have access to convalescent plasma. Sometimes there are sort of limitations or supply limitations. We're not convinced it works. So, I think what we have become much more aware of is supportive care and traditional pulmonary care. Clearly, the administration of steroids in appropriate timing for patients, the administration of remdesivir, if available, early in the course during the viremic period, as opposed to the immunologic period later. But I think we're in a better place in terms of what we know and therefore what we can advise patients. And I can't practice medicine in the sort of thinking about the medical liability issues for every patient. I have to treat every patient in the best manner that I can possibly. And I just tell the families the truth. We don't have access to that. We don't have access to this trial. We don't know that those things work. We know these things work. This is what we're doing. You're welcome to communicate to other hospitals or other places if you think it would make a difference for your care. We don't think it will. And I will personally accept that risk.
Yeah, I agree with everything Dr. Resnic said. I'll just add that we're about to have another probably go round with monoclonal antibodies. So the HHS and the local Massachusetts DPH have reconvened that committee for equitable allocation, because we know that there's not an adequate supply of either the Regeneron or the Lilly compound should they become authorized. So the focus on equitable allocation is going to be really important. And during the kind of height of all this, we actually had a system in place for if we had more patients than doses of remdesivir in our trials to equitably decide which patient would get it. And so that's part of the crisis standards group. They helped sort of develop that framework for equitable access to medicines. And I think, unfortunately, we may be facing that again, perhaps with the monoclonal antibodies, and we might with vaccines as well, based on what we know about vaccine dosing availability. I don't know, Dr. Thielman, what you've heard on that regard, but I know that people are talking about that.
Yeah, I'll just say, yeah, I think it's a huge issue. There are kind of two sides to this coin. One is, can we ramp up production for the most successful vaccines? And then the other is, will people take it to get to that 60% herd immunity threshold? And yeah, it's going to be a different, I think it's going to be a different environment in about 3 or 4 months. And we've got a lot of issues with vaccine hesitancy in the US. There's this weird thing with social media now that sends to polarize, and it's not going to take much for an adverse event to get reported out in a manner that's going to spook some people. So we have to, I think we really have to think about public health communication and leadership in all of this as it comes out.
If I could add one point, I was struck by the Minister of Health that because of resource limitations in Jordan itself, I believe the numbers were very small. The total population is 10 million, but yeah, the amount of vaccine at maximum that they're planning is on the order of, is it 400,000?
That was the influenza.
Oh yeah, I'm sorry.
Yeah, but the COVID, I think they're planning for 1 million doses, yeah, which is 10% of the population, and then they want to increase it to 20% of the population.
Yeah. So it's a completely different set of expectations and realities in the countries that don't have access to the resources that we sort of take for granted. It's a very, very big challenge, a true pandemic.
Dr. Al-Husami, do we have time for one more question, or time?
Yeah, I think yeah, you could give a quick question, then I don't want to hold the speaker so long. So thank you so much.
Okay.
Go ahead.
One more question. We'll try to zoom out a little bit to the 10,000-foot view. We have a nice question of, is there one strategy or a single recommendation of what the best way is to reduce the number of sick patients in the current situation in Jordan, where cases are rising, and all of our colleagues on the call would like to recommend something?
Maybe I'll start as the guy who tried to give an overarching view early on. And I think everybody echoed this. And the reason I think that you have such a broad range of experts on this webinar is because there is no magic pill, unfortunately. I think there are phases of this response, this pandemic response, each one equally important. And what you've seen presented here are some of the public health aspects of the response, and this idea of bridging ourselves as a community from the beginning of the pandemic to the point when we have effective vaccines and/or therapeutics. Then you've seen also a bit about the actual medical response of how we manage these patients, how we keep ourselves safe in the hospital as healthcare workers. And then how we, try to put all of these things together to get on the other side of the pandemic. So, unfortunately, there's no magic pill. The best I could say is the magic pill are, until we get the real magic pill, which is the vaccine and or a very effective therapeutic, it's a non-pharmaceutical intervention. It's doing the best we can to do the social distancing strategies.
I hate to be the person that asks a question in response to a question. Is there a national mask mandate in Jordan?
I think the government is reinforcing that, but I don't think there is a penalty for that. And it's like any other country. Young people, they believe less, and elderly people, probably they believe more. It is all over the places, but what I hear from so many people now, because the number of cases going up, more adherence, and the people, they're trying to be more cautious. However, you'll have the 10 to 20% people who's not adhering and not listening, and they will need some kind of law or penalty to prevent that.
I would contribute only because this was the angle that I sort of spoke to. I think every government, every municipality should and does, there's sort of many different goals of what planning and preparedness sort of are meant to support. But one that I don't think we talked about very much is simply trying to shield the healthcare system from being absolutely overrun in a sense of crisis, so that if you can flatten the curve through even non-perfectly executed NPI, non-pharmaceutical interventions, then at least you might be able to absorb the substantial number of patients over time in your existing capacity, healthcare capacity. But what I think we feared in that moment in sort of March and April, and what we saw in small pockets, certainly in northern Italy, but again in Queens, outside of Manhattan in New York, was literally hospitals being overwhelmed to the point where the care starts breaking down even to the patients who do make it into the hospital, with people dying in the emergency room, unable to be cared for. And these mitigating strategies that help just flatten, even if it doesn't reduce the total number of patients who get infected, the outcomes will be better if you can pace the burden on the healthcare system. And I think that's just part of a critical part of the planning.
I want to say one comment to the group. I mean, I get all the time questions on WhatsApp and text messaging, always asking vitamin D, vitamin C, zinc, multivitamin, and yet they don't use the mask. So, I mean, is there any rule to use zinc over the mask? I mean, I don't know. I have not heard this, but these gossips go viral, comes sometimes from Italy, sometimes come from Europe, sometimes comes from France, sometimes from China. And people, they love this kind of news. Any of you can comment on that?
Yeah, no, I would just suggest that your response should be, no, that only works when you wear a mask and anytime that you're outside of your own house. That's the only time. It's the only way.
Perfect response.
Yep, absolutely.
Any other comments from the speaker before Greg take over? Helen, Nathan, Fred.
Thank you so much for the opportunity. Get your flu shot. And, the communication part of this, I think it started at the beginning, the being trusted. Our group is starting to get pretty anxious as we see the surge coming back. And we had a couple of meetings this week where it's up to us to tell people it's going to end. We may have a hard road for a while, but it's going to end. We're going to get through it. We're in a better place than we were 8 months ago. We have some tools. And even though it's hard work, keeping the physical distance, washing our hands, covering our face, it's monotonous, it's boring, as my teenagers tell me, but it works. And so I think we have to find the energy and lead, as Dr. Thielman pointed out. So thank you.
Can I ask a quick question about this vaccine story? Because people, they're saying that the government might spy through the vaccine in your gene. And this is also another viral news all over the world. Can you comment on that? It's a joke, but it's real. People, they believe on that.
Well,
Not if you're wearing a mask.
Really. I love it.
Absolutely. Yeah. And I guess my final comment too is just that we're in this together. Wael, thank you for organizing this. I hope we can all stay in touch, and we're in it together. Thank you for doing this, Wael.
Thank you. Greg.
I would just like to also echo that. Thank you so much for really being the spark to put this together. I'd also like to thank those who work behind the scenes to really make this happen. Amalia Voskanian is here. Dr. FACEP is here. Susan Stempek also. Thank you so much for making this happen. It's remarkable. 10 days ago, this was not even a thought, and somehow Wael and Amalia got together and put this together, and it's really remarkable. We got the quality of speakers that we did. So I would like to thank all the speakers, everyone, His Excellency, Mr. Friedman as well, and I think we had a great experience.
Thank
So stay safe, everyone.
you all. Thank you so much.
Thank you.